Good morning, everybody. So my task today is to first thank the organizer for inviting me to accomplish the task of talking about brain-computer interface, the use and the rationale of brain-computer interface into rehabilitation field. So looking for to go on with the slide, I'm sorry. Because yesterday, this one. All right, okay. All right, thank you. Sorry, excuse me. Okay, so since the time is not that long and the field is really vast, both in terms of rehabilitation and in terms of brain-computer interface, so I will just touch briefly some principles in neurorehabilitation that are interesting for the brain-computer interface, the rationale of using BCI, mainly in post-stroke rehabilitation, the current state of the art, and some issues which are really important to be targeted and developed in the future and the future prospect. So first, the principle in neurorehabilitation. So what I would like to transfer, to convey today is the message that neurorehabilitation has witnessed really a huge change over the last 10, 15 years. And the huge change is that from the art, in quote, of rehabilitation has moved into a field, a discipline. So becoming a real discipline in medicine, and this is mainly due to the huge advancement in terms of neuroimaging and animal basic studies, so the knowledge coming from the neuroscience field, which has highlighted one important aspect of how the central nervous system reacts to the presence of a lesion, and meaning that he adapts, changes in response, generally speaking, in response to intrinsic or extrinsic experience. And this goes holds through for during development, during learning new skills, motor or cognitive, and during and after the presence of a lesion or a disorders of the central nervous system. So this is all known as a neuroplasticity, which is which encompasses all the capability of the CNS to respond and adapt with structural and functional changes together. So then the neuroplasticity is essential for the spontaneous recovery after neurological injury, but we have to keep in mind that neuroplasticity is not, at least after a lesion, is not all good, because there are some maladaptive adaptation of the brain, which do not help the through recovery, which do not help the recovery of a function, which is what we as close to normal as possible. So in the end, now neurorehabilitation aims to maximize the experience or training dependent neuroplasticity, and also to integrate some compensatory strategies in order to ultimately achieve an improvement in function, independence, and quality of life. Okay, so the change I was talking about before can be summarized in a very simple way here, in a sense that the ultimate goals, it was and it is, to restore and maintain functional independencies, participation, quality of life, despite of impairments. So the art was that physiotherapists were there in order to help the patient to learn how to compensate a deficit with unaffected limbs or assistive device, and so any other strategy that I didn't mention, but they are there. So the discipline instead is based on the knowledge from the neuroscience field and into the translation of this knowledge into the clinical context in order to develop new strategies which are based on the mechanisms underlying neuroplasticity in order to foster a true recovery, and also when it is not possible, which is in many cases a compensation. So in this sense, neurorehabilitation is also participating. It also gives opportunity for evidence-based medicine that is really the real state of the art in medicine right now. So evidence-based medicine, personalized medicine, and so on and so forth. So now in this talk I'm going to focus for several reasons on stroke rehabilitation and application of BCI in stroke rehabilitation. Of course, it is by all means not the only part of neurorehabilitation, because different and several neurological disorders can be and have to be rehabilitated. Traumatic brain injury, spinal cord injury, and other cerebral palsy neurological diseases. So why in the end, in 25 minutes or whatever it is the time, I choose to talk about stroke? Because stroke is one of the first leading causes of disability, permanent disability in the world, no matter if this is in developing or undeveloped countries. It is a financial burden on healthcare systems in any countries. And for stroke, we do have now sufficiently well-documented benefits in terms of behavior and knowledge about the cortical plasticity mechanisms going on in response to a post-stroke lesion, which are induced mainly by exercise training. So this is only to show you or to make the point that many things happen after stroke, beginning from a minute after the lesion, going on for several hours, days, weeks, and months. So I put this here in order to show you that there is the improvement in recovering function is something that is more or less continuous, and several areas knowing which are the mechanisms can be the target to rehabilitation, to medicine, generally speaking. So we are located here, functional plasticity, which means that with BCI and other techniques, technology, we can foster, promote functional plasticity in order to recover function. And this is true in humans, but it came out basically from the tremendous amount of knowledge in basic research in animals with artificial model of stroke, where it was possible, and it is still possible, and it will be, to have knowledge about how the brain reacts and which are the mechanisms over time that helps spontaneous recovery. Because in the end, the neurorehabilitation helps spontaneous recovery. It is known now, for instance, that the recovery depends, recovery of function, also on our genetic profile, which means that somehow we are genetically programmed to recover after a lesion or after a disorder of the central nervous system, up to a certain point. Okay, so stroke is also an example of this virtuous circle in which medicine, neuroscience, and engineering are talking together, and hopefully more and more in the future, in order to exploit at the maximum the knowledge. So, and this is somehow summed up here, while I show that these are pictures taken from several work that has been done. So this one in particular here is just to show that when you have a stroke lesion, you have a depression of the peripheral perilesional areas. You have an over inhibition from the healthy hemisphere onto the lesioned hemisphere. And this is because the balance between the sensory motor areas, mainly between the two hemispheres, is interrupted or mainly reduced, because the lesioned hemisphere cannot impact on the healthy hemisphere that much as it was before the lesion. And so that's a general picture, but still very valid, yet very simplistic as I schematize it here. And how we can act on this? We can act by task-specific training, exercise, and so that we can act on the lesion at the hemisphere, retraining, engaging the sensory motor areas, the perilesional areas, in order to regain function, so recovery. We can act also on trying to induce more engagement on the hemisphere by artificially stimulate via RTMS, TDCS, and you know all the paradigms that you can use in order to engage the lesion at the hemisphere. But you can use the same neuromodulation, that's the term to indicate all of these techniques and methods to non-invasively stimulate the brain. So you can neuromodulate the healthy hemisphere, meaning that you can somehow put down, inhibit the healthy hemisphere, trying to re-establish this balance. And so the task-specific training from the periphery, let's say so, can be done with a therapist, but by now many technologies can help this, via robotics, virtual reality, functional electrical stimulation, and BCI, of course. And so what is important here is also to have in mind that more and more studies and work is on combined strategies, because not all the stroke lesions are the same. The position, the side and the site of the lesion makes a very important difference between patients. And so there is not one technique, not one approach that will solve the problem of all stroke patients. But in stroke particularly, we have to think about personalized strategies, and these personalized strategies are for each more or less single patient, or at least classes of patients, together with the time, considering the time. The recovery goes on, fortunately, and you have to modulate your strategy according to the ability to recover of that single patient. So combined strategies appears to be a key issue. Unfortunately, nonetheless, substantial percentage of stroke patients do not benefit from all of this, and these are the most severe, impaired with a lower or upper limb, I'm talking about motor deficit mainly. And actually this class of patients should be the class of patients we target too, because they are the most severe, and they are those who do not really respond, or do not respond as much as we wish or we hypothesize to the several combined strategies. So now brain-computer interface. So I summarize on the left-hand side here some key issue in neurorehabilitation after stroke, principally motor. So we know that extensive task-oriented training programs are good, because there are several large randomized controlled trials to indicate that they really improve the functional motor function. And so they are based on rewarding performances, very important concept. Adherence of the patient to intervention, it's another key point. So then retraining the brain area associated to the function and enhance finally neuroplasticity. Now if you think about BCI, I think we can say that with reasonable confidence that the brain-computer interface can virtually cover all these aspects. Because I don't have to tell you what is brain-computer interface, but you know that it can directly measure signal from the damaged cortical areas and translate them into close to normal motor outputs, providing online instantaneous feedback on performance. So we can say that BCI is good for the first and the second point. Also the third point, adherence to intervention. You can actually monitor the adherence to intervention of a patient via BCI. Of course, this we can say that this adherence can be even monitored by monitoring the brain activity. So, and in the future, not that far away, when the machine will be able really to monitor how the changes of the brain, or actually the changes related to the activity the patient is putting forward during his exercise, can be displayed to the therapist, then we can really measure the adherence to intervention. Retraining brain areas, enhancing plasticity. We all know that brain-computer interface is very promising in this, and there are already out there demonstrations that brain-computer interface can change, can potentiate, enhance neuroplasticity. So this is all good, and so now let's go and see what is the rationale to use brain-computer interface. I use this scheme here. We all know this. Is taken from Daly and Wolpone in 2009, where mainly two strategies are indicated in order to use brain-computer interface to finally, ultimately regain normal function or close to normal function. So the strategy which is indicated in number 1 is a strategy where you have CNS producing activity, brain activity, and so you have your signal feature, you extract this feature, and you feedback the changes of this brain activity, which means that you somehow directly train the cortical signal, okay? So the loop contains brain activity. So while inducing or promoting more and more close to normal brain activity, this in turn will return, excuse me for the word, return close to normal function, so close to normal efferent from the CNS. The strategy number 2, you have within the loop a control of a prosthetic device, and can be robotic, can be functional electrical stimulation, can be any other orthesis that you can or you wish to insert in the loop. And in this case, the brain activity control the external device and induce more normal afferent signal, helping the movement and going back to the CNS. So in this case, the closed loop will give you close to normal movement afferent going back to the brain, and in the end this will turn out as an improvement of function. So now this other picture I summarize actually this brain strategy number 1, 2, which are what I show you today now, and we also like to think that there can be another third training strategy where in the loop of the brain-computer interface we can also combine some non-brain invasive stimulation, which means, and there are some very basic studies out there, and which means that the brain-computer interface can also impose somehow the right time, the good time when the stimulation, the neuromodulation actually can put its effect on the brain. So combining different type of neuromodulation, because we can think about brain-computer interface as actually a way to neuromodulate the brain non-invasively. Okay? Although classically the neuromodulation is done via stimulation of the brain. Magnetically or electrically. So all three strategy goes into improved function. So now I'm going to show you some studies, which by all means are not all the studies out there about brain-computer interface and stroke, because these are, fortunately, because this means that there is a lot of awareness and interest on it, impossible to do it in 20 minutes. And so I had to make a choice. And so the choice was just to show you only studies which are examples of the three strategies. Mainly the first two strategies are study on patients, are randomized controlled trial, which means that there are a number of patients and groups different between them. And so the first one, it's about strategy number 1, which means that you train brain activity, basically, and you target by doing this one function. In this study, the brain activity was the activity produced through motor imagery. So because motor imagery is known to be promising, and now is actually, I think it has been demonstrated, a backdoor stage to access the central nervous system after stroke. So here the patient imaged to close or to open the hand, only the affected hand, according to the rehabilitation principle, as also the signal were taken only from the affected hemisphere. So the motor imagery was well studied before the training via high density EEG in TMS, and so each patient was characterized about this. So 1 month of training in patient performing motor imagery with BCI compared to a group of patients performing motor imagery alone, we could show that there is an increase in some functional motor scales, and also some indices of the brain network change after the 1 month training in BCI group correlated with the Flügel-Meyer, so with clinical scale, which means that reasonably this can be used somehow as a measure of the improvement, and also some changes in the interhemisphere connection were also seen on BCI group. Another study here is somehow an example of the second strategy, where you have a brain-computer interface which controls a device on the affected hand. We are still talking about stroke patient, and orthesis that can allow patient to close or to open the hand. Again, the signal is from the affected hemisphere based on attempt movement motor imagery, and 1 month of training induced a change in the laterality index, which means that the balance between the healthy hemisphere and the affected hemisphere was somehow re-established in BCI a group of patients compared to the control group. Another study here, we are focusing on the lower limb in the stroke patient. Here is interesting, the approach, because as the author called it, is an associative BCI, which means that they make the trigger of the brain-computer interface exactly at the point where the motor-related cortical potential generated by attempted movement displays the reflects the maximum point of plasticity. And so the BCI starts at that point, is aligned with that point of the MRP, and so in this case, stroke patients ameliorate their function of the lower limb compared to patients who did not have this type of BCI, and also the author showed that the motor evoked potential increased after, right after the intervention, and also later on, 30 minutes actually post-intervention, indicated an increment of plasticity then. So finally, the last study is about not really combining, but starting to combine TDCS with brain-computer interface. Particularly, the author here allow patients to go under a TDCS session and then have a training with the brain-computer interface compared to a sham TDCS and then brain-computer interface. And actually, although the increment in functional was not that relevant, the author were able to show that there is an increase in an improvement in the performance at the level of brain-computer interface. So TDCS can promote the learning and the use of brain-computer interface. So to close, just to sum up some key issues, and based on what you have seen, there are several clinical trials around. These clinical trials are group study on chronic or subacute patients. We have these are limited study in time, so there are no follow-up study out there and yet. And side effects, which means that we don't know fully, we don't have the full knowledge right now on plasticity modulation in this type of concept. So we still need to progress on this. And so these are actually 3 main points that hold for new technology rehabilitation. So on the one hand, the good news is that BCI is not alone there to solve some problem, but also it's comparable to other technology. So, and of course there are problems related to hardware, software, classification, and so on and so forth, which I didn't touch here because we have several workshops to talk about it. The future. So here I just list some key issues which can be changed, and I hopefully they will stimulate discussion along across the workshop. So what is really important here is the synergy, again, remember the beginning, between medicine, neuroscience, engineering to address first a general consensus of what has to be done next, which are the priorities, how to exploit what we have now and not to just put it aside and start over again. Elucidate the selectivity of different BCI-based strategies. No one BCI for all patients. Actually, several strategies for several classes of patients. Who are the best candidates for BCI? Follow-up study. Comprehensive evaluation of outcomes when you apply a BCI, which cannot be only the performance if you have 100% of performance. So all of this will really bring us, the BCI community and the BCI, to a sensible innovation technology for stroke rehabilitation and in the future for other fields in neurorehabilitation. So I close and I thank you very much for the attention.
Donatella, that was really good summary. Very exciting. I had one addition, I think, to the future prospects, that I think it's important that there be controlled studies showing not only that BCIs can help, but that they can add, that they can enhance beyond what conventional therapy does. That's really going to be important for them to be incorporated in clinical programs and to be reimbursed.
Yeah, right. That is a very relevant point, because in neurorehabilitation we do have the problem of who is going to pay for it, and so this is, it has to be in the list. This is only an example. I wish the list will increase. Okay.
Oh, thank you so much. Really fine, comprehensive, optimistic presentation. I really appreciate it. I would like to add to what Dr. Wolpaw has just mentioned too. In the field of rehabilitation, there's a new push to consider what is a minimal, clinically important difference. And for our measures of success in terms of motor behavior or cognitive improvement, we should be careful to utilize those measures of what, for a particular measure, what is the value, what is the number of points, if you will, that is a minimal, clinically important difference, because I think that is really where the field is going, not just because it's a bit more statistically significant improvement, but does it provide a minimal, clinically important gain?
Yes, you are right, and yeah, I fully agree with you that is not just the increase, a discrete increase of the Fugl-Meyer scores or other scales that you can consider as a change in terms of functional improvement. It has to have a clinical meaning. And there are already out there way of knowing somehow what has to be your increment to be clinically relevant for several scales. Fugl-Meyer is the first one. And also to consider effectiveness, so which is a ratio between what you can expect from that patient to recover according to the situation, the clinical status at the moment of the study. So, very good.
Thank you, Donatella.
Oh yeah, all right.
Sorry.
Who is first?
Nice talk. We start to see that BCI can potentially help in neuro rehab and stroke. I have two questions in this regard. What is the right timing and dose of such therapy in addition to standard practice? The second question is, beyond stroke, in what other neurological problems can we use BCI as a rehabilitation tool?
Okay, first question is, what is the right time? That's a good question. This is not only for the BCI, but generally speaking, we know that the first 3 months are the right time if you want to target, or the idea is to target plasticity, because that's a period where these are most active in this term. But there are now indications that also in what you call a chronic phase after stroke, after 6 months, you can still have some improvement. But I would say that the sooner the best. So the second question, sorry, I don't remember what was.
Beyond stroke, which other indications can we use this tool?
Beyond stroke, yes, of course. Although the literature is much less rich than with respect to stroke, there are studies about neurofeedback, which is promising for treating attention, memory disorders, and stroke, and also after traumatic brain injury, which is another good important point in neurorehabilitation. And basically, if you use a BCI to correct strategies, you can even think about Parkinson's diseases for tremor, for instance. So there is quite a large possibilities, opportunities for BCI.
Yeah, sure. How do you balance, you mentioned the need to personalize this for each patient, but how do you balance that with the need to conduct rigorous and adequately powered studies to assess efficacy?
Yes, that's a good question. Okay. Now the balance. Of course, the group studies are important, but of course I'm not saying that you have to study one patient and another one and another one. It's to use the knowledge in order, and we do have the knowledge now to do that, to classify classes of, to define classes of patients with certain characteristics that allows you even to predict the amount of recovery that you can expect, and then compare this by using BCI. In this sense, I say personalized medicine, of course, not doing single case study. Okay? I think I'm done. Thank you.